Okay, ladies and gentlemen, we're moving on with session 2. After a very nice first session, I think also in session 2, I think we have a very nice and good lineup. And welcome back also on behalf of my co-moderator, Mark Sulkowski. We'll start with a talk given by Morven Cunningham, who is actually working at the Toronto Centre for Liver Disease. She was trained at Cambridge in the UK, went to Queen's Mary, University of London, came over to Toronto in 2017 as a fellow in hepatology and never left us. And we're very happy that she stayed around. And she did a lot of work, particularly on hepatitis associated with checkpoint inhibition, and today she'll broaden that up to autoimmunity in general in the setting of checkpoint inhibition, which is sometimes maybe acceptable in the setting of oncology treatment, but for hepatitis B patients who are relatively healthy with a good prognosis, it is definitely something to be concerned about to a certain extent. So, Morven, please go ahead. Thank you very much for coming.
Thank you very much for that introduction. Thank you to the organisers for inviting me to speak. This will be a little bit of a change of pace from the earlier session. These are my disclosures. The objectives of today's session are to talk a little bit about our understanding of the pathophysiology of immune-related adverse events, which is the terminology, as you're aware, that's often used to describe the toxicities related to immune checkpoint inhibitor therapy. We'll talk about incidence, timing, and the nature of the more common immune-related adverse events, and a bit of an overview of their management. Significant limitations and disclaimers before I even start on any of this is that really all of this data comes from the land of oncology, and everyone there has a tumour. Sometimes they have quite a lot of tumour. We don't have much data that's outside clinical trials. Very few patients have underlying liver disease or viral hepatitis, certainly in the data where much of which I'm going to present today. But most of these patients do have advanced oncological disease, and a lot of them have had more than one line of potentially quite toxic chemotherapy. So overall, you're creating quite a different patient population. Not included on this slide, I am a clinical hepatologist. I'm not a virologist. I'm definitely not an immunologist, and I'm not an oncologist. So take from the rest of this talk from what you will. All of that being said, I think this audience is very familiar with the mechanism of action of immune checkpoint inhibitors, but for anyone who may not be so familiar, these are monoclonal antibodies which are targeted generally against CTLA4 or the PD-1 or PD-L1 axis. Generally speaking, they give the immune system that kick we were talking about earlier. They increase effector T cell function and proliferation. They work in slightly different non-redundant ways, but globally, our understanding of their function and the way that they interfere with immune homeostasis to result in these adverse effects is through their effects on effector T cell activation and proliferation, their reduction in T regulatory cell function, and through increased pro-inflammatory cytokine production. And there's quite good animal model, preclinical, and translational evidence to support these mechanisms. They may have effects more widespread on B cells and enhanced humoral autoimmunity. And in the land of cancer, there's potentially a mechanism where there is antigen cross-reactivity. So your effector T cells may recognize antigens that are present in the tumor, but also similar antigens present in host tissue. And there's some evidence to support that. Other models that I actually quite like, separate toxicities into toxicities that you see at barrier tissues, so at the respiratory epithelium, the skin, and the GI tract, where potentially you have a population of effector T cells or immune cells that have been exposed to bacterial antigens, but under normal circumstances are suppressed by immune homeostasis, to put it simply. And when you disrupt these mechanisms, you potentially activate these cells. And that's one explanation that's certainly our hypothesis that's proposed for toxicities that occur at these barrier sites. Toxicities don't just occur there, they can actually affect any organ system. And it's slightly harder sometimes to explain how you get immune side effects in more sterile sites, but it certainly happens. Mechanisms that have been postulated are around perhaps autoreactive T cells that may not have been cleared by the thymus that are then allowed to run rampant. Again, we don't really know, and a better understanding of these toxicities will be important, particularly if you're looking to use these agents outside the cancer setting and in people potentially who are otherwise healthy. The end result is an immune-mediated attack on healthy tissues. It sometimes gets described as being like autoimmune disease. It's not exactly the same, and the good example that I'm most familiar with is autoimmune hepatitis. And checkpoint inhibitor hepatotoxicity is really quite different in terms of its presentation and its response to treatment to checkpoint inhibitor hepatitis, and it's the same in other organ systems too. So this gives you just an overview in the top panel A here of some of the clinically important immune-related adverse events with PD-1 blockade or with anti-CTLA-4 containing therapies. As you might expect, as the mechanisms of action are slightly different, the predominant toxicities that you see are slightly different. But I think the take-home message is that toxicity can pretty much affect any organ system, and any clinical syndrome that you care to imagine has probably been described in association with checkpoint inhibitor therapy. These are clinically important because these are the ones that will occur more often or maybe less common, but are potentially much more severe and maybe even fatal in a small number of cases. Panel B down at the bottom there shows you that there's an inverse relationship between frequency and severity. So the toxicities that you see most commonly, skin, joint, gut, fortunately are not so severe, but the toxicities that occur less commonly, nervous system, heart in particular, have the potential to be fatal. There are some postulated risks for individual patients to develop immune-related toxicities. Unfortunately, we cannot clearly predict those for an individual patient at this point in time. It would be great if we could. I'm talking about frequency, just to put some numbers on that, and bearing in mind, of course, this is all from cancer clinical trials. These are some combined data from phase 3 trials of combination therapy, anti-PD-1 and anti-CTLA-4 in purple, anti-CTLA-4 in green, and anti-PD-1 therapies in orange, just showing the reported incidence of various different organ-specific immune-related adverse events. So if we focus maybe more on the PD-1 side, which is the orange bars, about 15% of patients developed the more common side effects, generally colitis in GI, dermatitis. Pneumonitis are affecting the lungs, potentially more severe, perhaps 5% in these trials. Subsequent real-world experience actually suggests that might be a little bit lower, more common in PD-1 than PD-L1. The neurological or cardiac toxicities are not included in this study, but have been reported in perhaps 2% of cancer patients treated with PD-1 or PD-L1 therapies. Checkpoint inhibitor toxicities typically occur relatively early in therapy. Now, of course, bearing in mind these patients are receiving ongoing, sometimes very long-term courses of treatment. They're not just getting one-off infusions. And you tend to see the treatments emerging somewhere between weeks 4 and weeks 12 of therapy. Having said that, it's very important to recognize that there's a huge variation described here, quite different to other types of drug toxicity, and the latency can be as short as a few days in some cases, but there's also been reports of checkpoint inhibitor toxicities after patients had been on treatment, stably maintained on treatment for many, many months, and even in 1 or 2 cases after patients had completed therapy and been off therapy for up to a year. So any patient who's been exposed to checkpoint inhibitor therapy, you kind of have to maintain an index of suspicion for immunotoxicity. Just going to spend a few minutes working my way around this little flow diagram, which just to focus on a few key points in the management of these toxicities, particularly for patients who are treated with checkpoint inhibitor therapy. It would be great if we could prevent it from happening. That is tricky because we don't know exactly why it happens and we can't predict who it may happen for. We do recognize, certainly in the world of oncology, that there's an increased risk with combination checkpoint inhibitor therapies, and there's an increased risk in patients with pre-existing autoimmune disease. They definitely have more risk of flare of their underlying autoimmune disease, but they also have a higher risk of developing de novo immune-related toxicities. Any patient who's starting checkpoint inhibitor therapy needs a really thorough baseline assessment, and they also need very close on-treatment monitoring, physical exam, and a whole panel of blood work. And that's usually timed to coincide with their infusions. Again, bearing in mind that these toxicities can develop after a significant latency, that follow-up needs to continue even after the patient completes treatment. And how long that's for is an open question. If patients do develop symptoms, it's a good idea to have a low threshold to investigate those. Some of those more significant toxicities, the cardiac toxicities, the neurological toxicities, have the potential to progress very rapidly. And I'll touch on fatalities in just towards the end of the talk, but in patients who did die of myocarditis, for example, the time from onset of symptoms to death was 30 days. So any new symptoms really do need to be assessed. Toxicity is a diagnosis of exclusion. There's no diagnostic test that will confirm that your patient does have checkpoint inhibitor-associated toxicity. So outside the oncology world, we don't have a great feel for how common these toxicities are likely to be. And it might well be that your patient has got food poisoning and does not have checkpoint inhibitor-associated colitis, and you don't want to be stopping therapy and giving them high-dose steroids for Campylobacter, for example. So if in doubt, involve a specialist early. That's, I think, the message that we've kind of sent to oncology from hepatology. We like to know about these patients who develop checkpoint inhibitor hepatotoxicity. The knee-jerk response has often been to say, well, they've had a checkpoint inhibitor, it must be hepatotoxicity. We'll stop the checkpoint, we'll start steroids. And we've published data to show that actually in the liver, patients treated for various primary malignancies with checkpoint inhibitors, about 85% of them actually have a different cause for hepatitis. It's not checkpoint inhibitor-associated hepatotoxicity. So think of other causes, check for other causes, speak to a specialist. If the patient does have checkpoint inhibitor hepatotoxicity or all other reasonable causes have been excluded, the severity of the toxicity is assessed using the common the terminology criteria for adverse events, which are derived from oncology clinical trials. And this really reflects the fact that all the management guidance is derived from oncology clinical trials, some anecdotal experience, and some retrospective series. There are some very detailed management algorithms that are laid out in the Oncology Societal Practice Guidelines. They're very, very helpful, especially if you're dealing with things that you don't normally deal with. And they're effective, but they have never been prospectively evaluated for any of these toxicities. These are a couple of good examples from the European Society of Medical Oncology and the American Society of Clinical Oncology, to name but two. These are probably the most common two that are referenced. A broad overview splits the toxicities from 1 to 4. There is actually a fifth toxicity, which is death, but for practical management, that's probably not so relevant, unfortunately rare. Grade 1 toxicities can normally just be monitored while you consider investigation for other causes. Grade 2 toxicities generally involve holding checkpoint inhibitor, and depending on exactly what organ system is affected, you may wish to investigate. You may even wish to start treatment if you're worried, if it's neurological, if it's pulmonary, if it's cardiac. You're going to have a lower threshold for worry with those toxicities. Grade 3 and 4 is when people are getting sick. Usually involves organ dysfunction, usually involves stopping the checkpoint inhibitor, possibly indefinitely. Again, in the land of oncology, patients may not have other good treatment options. They might get rechallenged, but even then, there's a concern. These patients will almost always be treated and may require admission because, as I've mentioned, some of these toxicities can progress rapidly. Just a few exceptions. Dermatological toxicities, you can often manage those quite simply in topical therapies. Endocrine toxicities may be permanent, actually, and usually require replacement therapy, but not immunosuppression. But for most other toxicities, eye-wateringly high doses, sometimes of corticosteroids, are the mainstay of management for most patients who need treatment and don't resolve simply with withdrawal of the checkpoint inhibitor. It's important then to monitor the patients for the complications of the treatment. You've monitored them for the complications of the checkpoint inhibitor. Now you've potentially put them on 2 milligrams per kilogram of prednisone. There is a significant risk of infection, hyperglycemia, well reported in the literature, so it's important not to stop monitoring them at this point. Some patients do not respond to the steroids. Fortunately, the majority do, but there are a whole array of second-line immunosuppressive therapies that have been developed and tried and tested depending on the specific organ toxicity. Anti-TNFs work pretty well in colitis. We tend to use mycophenolate mofetil for immune-related hepatitis, for example. It's a good time to check the diagnosis. If you haven't involved a specialist up to this point, it's a good time to do that too. Generally speaking, once the toxicity has resolved and you've been able to taper off the steroids if you had to use them in the first place, that specific toxicity does not tend to recur unless you re-challenge the patient with a checkpoint inhibitor targeting the same pathway. But remember, different toxicities have different latencies. In hepatitis, for example, we do actually see emergent checkpoint inhibitor hepatitis as patients have their steroids tapered for some other kind of toxicity. So different toxicities can emerge. Unfortunately, it's not one and done. Most of these toxicities resolve over about 4 to 8 weeks, and that's whether or not patients have required immunosuppression. Remember, some patients, unfortunately, do develop permanent consequences. Endocrine toxicities often involve a permanent loss of function. Joint symptoms may be chronic, and patients with pulmonary disease may develop a chronic pneumonitis. In this series of about 4,000 patients treated at specialist centres, there was about a 0.6% fatality rate associated with toxicity, and the majority of those were due to heart, nervous system, or lung toxicity. So those are really the ones to watch out for. So in summary, checkpoint inhibitor toxicities are seen fairly commonly, certainly in the context of checkpoint inhibitors used as an anti-cancer therapy. In other settings, the frequency remains unclear. Generally, frequency is inversely proportional to severity. Close monitoring is required to detect these toxicities early, as some can cause permanent morbidity and very rarely mortality. Thank you.
Well, great. Well, thank you, Dr. Cunningham, for that very interesting talk. They'll give us some food for discussion a bit later. We're going to continue with the theme of I suppose, toxicities or perhaps therapeutic advances, and invite MF Yuen to the stage. He needs really no introduction, but I'll say a few words. He is professor and chair of the Division of Gastroenterology and Hepatology at the University of Hong Kong, and he is a leading clinician scientist, leading multiple clinical trials of immuno-based as well as antiviral-based therapies for hepatitis B. And he'll talk to us about therapy-induced flares associated with hepatitis B S antigen decline.
Thank you, Mark, for the very kind introduction. And also, I'd like to thank Harry and Adam for inviting me to talk on this very special topic, therapy-induced flares associated with surface antigen decline. And I will cover some of the novel agents, including ASO, anti-PD-1, stop loops, LAPS, and also siRNA. From time to time, we see patients with spontaneous ALT flares, and this can happen both in the E-positive phase or E-negative phase. And it was estimated to be around 27% and 10% respectively. And these flares sometimes can result in ECU conversion, and some people will also end up with surface antigen zero clearance, which is a better outcome for the disease. It should be noted that in different clinical trials, they use different normal ALT levels. Some will use 40 to 45 for both sex, and some will use 35 for male and 25 for female. To define ALT flares, we usually refer to the ALT levels greater than 2 or 3 times the upper of normal for those who had normal baseline ALT. And for patients with elevated baseline ALT, we usually define ALT flares at least increase of twofold from the baseline. In fact, flares is actually not bad sometimes. And in our most recent study, looking at spontaneous flares with patients with ALT greater than 10 times, in fact, we actually have a discussion in the last section. When we follow up these patients with very high flares, they actually had a higher chance of getting subsequent surface antigen seroclearance after follow-up. However, if the flare is severe and uncontrolled, we may sometimes encounter the risk of liver decompensation and even mortality. How about patients who receive treatment? And we know that patients who received nucleoside analogs, sometimes we encounter patients with flares, and they usually subside spontaneously. How about patients receiving new treatments? We know now that patients receiving new treatment that can lead to surface antigen reduction, and that we always say immune awakening, that will also be associated with flare. But in clinical trials, we also need to look into whether this flare is related to what we call drug-induced liver injury, DILI. And we now also advocate the stop NUCs therapy. And in that particular context, this patient's flare will be related to the rebound of the viral replications, and that induces the immune-mediated attack. There are some important clues of flares when we manage the patients that will give us some idea whether this is related to the drugs or related to the disease, related activities. Firstly, the timing of flares. Obviously, if the flares occurs during treatment, then we will think about whether this is hepatitis B-related flares or the drug-induced toxicity. If the flares actually occurred after stopping of treatment, we usually think about whether this is related to the activities rather than the drugs. Secondly, in a more granular level, the temporal relationship between the drug administration and the flares is very important, and that can be taken into consideration for us to decide whether it's likely to be drug-induced or hepatitis-related flares. I will show you another example in the subsequent slide. And finally, if we can observe an obvious association of the reduction of the viral materials during treatment, then we will think that they will be more likely to be lowering the surface antigen because of the new drugs, and that induce the immune flares, and sometimes we call it good flares. So in this particular patient, he actually received siRNA at every 4 weeks. And after the first dose, the ALT actually increased to around 120. And then after the second and the third dose, the ALT actually increased to around 140 to 150. And the highest ALT of around 200 was observed after this fourth dose. And then subsequently, these patients had the flares of ALT around 100 and below 200, and then subsequently subside with normal ALT after finishing of the therapy. The absence, or the fact that there was no further upsurging of the ALT after the fifth and the sixth dose may more indicate the flares are related to the surface antigen lowering effect rather than drug-induced toxicity. However, we cannot totally exclude the possibility of DILI in this case. That comes with the importance of lowering the surface antigen during therapy in patients receiving siRNA. And we still don't know whether these flares are more likely to be immune-related due to the surface antigen reduction or DILI in this particular case. To illustrate the point of, or the importance of knowing the surface antigen level during therapy, I would like to illustrate 2 examples to you. The first patients actually had the ALT flares just after a very rapid decline of the surface antigen of around 2 log after a single dose of siRNA. And the second patient below have 3 episodes of flares. The first 2 actually coincide with a 1 log reduction of surface antigen after the single and the multiple doses of siRNA. And in fact, the last flares was actually well after the completion of the siRNA treatment, and in fact was related to a concomitant febrile illness in this particular patient. We always say that, the low surface antigen knowing effect of siRNA will induce or reawaken the immune system, and this study supports the hypothesis. And in patients receiving HBsAg siRNA, we identified 7 patients with documented upregulation of the hepatitis B specific T cell activation, and that was, reflected by the measurement of the interferon gamma, illustrated in the brown bars in the diagrams. 5 patients had the ALT flares, 5 patients with interferon gamma production coincide with the surface antigen decline. And some of these 5 patients actually have coincided with mild to moderate ALT elevation. And 2 patients actually have the interferon gamma production after the completion of the HB729. Similar to what we have observed for patients with spontaneous ALT flares leading to surface antigen zero clearance, we also see patients who received no full therapy with or without interferons leading to the loss of surface antigen. And in these 3 patients, they actually received VIR-2218 plus pegylated interferons, and you can see that the ALT flares actually occurs during the declining period of the surface antigen. And after 24 weeks of therapy, these 3 patients actually lost the surface antigen. Similar to what we observed in the siRNA, we also observed the association between the flares and the decline of surface antigen in patients receiving antisense oligonucleotide bepirovirsen, BEP in this case. But I would like to draw your attention to the magnitude of the ALT flares in patients who were already on nucleoside analogs. And you can see that these 3 patients have flares after the surface antigen decline. And in fact, the peak ALT during the flares were around 200 or 250. And they all actually, spontaneously subside, even without doing anything for these patients. However, when we look at another patient who received the same regimen of the ASO, who is not on nucleoside analog therapy, in fact, we can see the temporal association of the surface antigen and also the ALT flares together with a DNA reduction. But you can see these patients actually have the very big flares in terms of the level of the ALT compared to the 3 patients who are on nucleoside analogs. These patients have the flares of 800. In addition, what they've observed is they find there was an association between the magnitude of surface antigen reduction with the ALT AUC, meaning that the greater the surface antigen reduction, the higher is the ALT during the flares. In addition, as mentioned, patients who actually were naive, they actually have a higher magnitude of ALT flares during the therapy. Not only we see, the ALT flares and the surface antigen decline association in siRNA and also ASO. People receiving other novel therapy, in this case, for example, the surface antigen release inhibitor, the NAPs, actually also showed a similar phenomenon. You can see in both cohorts, with the profound decline of the surface antigen after the administration of the NAPs, there are many patients who actually have ALT flares. And not only that, further analysis showed that, similar to ASO, they actually find there was a correlation between the magnitude of surface antigen reduction and ALT levels, but only limited to those with surface antigen reduction greater than 3 logs during the therapy. And patients who achieved functional cure subsequently has a trend of lower surface antigen level at the time of flares. So all these actually indicate that the association or the relationship between ALT flares and surface antigen actually exists in patients with receiving different novel direct antiviral agents. So the question is whether would it be the same observation in patients who receive immunomodulators? This is a study using the lock nucleic acid liver targeting anti-PD-L1. Treated the patients with 5 doses. And you can see, although the mean surface antigen level was not particularly high, around 0.3 logs, but we can see one patient, at least, who had a very nice drop of the surface antigen represented in the blue line, accompanied by an increase in ALT represented in the brown line. So we did see patients with receiving anti-PD-L1 having the association of surface antigen decline together with the ALT flares. And monoclonal antibodies, in this case, avelumab, targeting the anti-PD-1, also showed the similar things. ALT flares was observed in 21% of patients, and 9 out of 10 patients with the flares show a very obvious downward trend of the surface antigen. And in fact, they have 3 patients with sustained surface antigen loss, and 2 of them, they had experienced ALT flares. And this is the diagram showing you the serum profile of this, one of the 2 patients with ALT flare ending with surface antigen loss. And these patients actually had the cessation of both the anti-PD-1 and the Lux, and the surface antigen remained to be undetectable 24 weeks after stopping both treatments. So we discussed the patients in greater detail with ALT flares during the novel antiviral therapy. And how about stopping Lux? Whether it occurs or what is the outcome of stopping Lux? And in fact, I think Professor Lampertico will also discuss it in greater detail. What I'm going to show you is the results of stopping Lux of patients with 2 cases. And in fact, before that, the benefit of stopping Lux, we know that is the occurrence of the surface antigen seroclearance afterwards. It was estimated around 13% after 4 years of stopping Lux. And you can see that white patients had a significantly higher chance of getting loss of surface antigen compared to Asian population. However, around 30% of these patients who stopped Lux had the what we call ALT flares. And sometimes we see patients with liver decompensation estimated to be around 4.5% in cirrhotic patients and 0.8% in non-cirrhotic. And sometimes we see mortality out of these flares. So we always strike the balance between the risk of liver failure versus the benefit of achieving functional cure when we consider stopping Lux. And I think, personally, I think the key important factors is the patient selection and also the monitoring strategy for patients who opt to stop Lux. And this is one example of our own trial, stopping patient Lux, and then we find that 21% of these patients actually have ALT elevations with flares, and 4 actually developed grade 4 ALT elevations. The peak of these 4 patients was around 1,324. And this is a profile or diagram showing you the profile of the ALT together with the DNA at different time points of these particular patients. And you can see over 1 week, actually the DNA actually increased by 3 logs. And in fact, there is no ALT elevation at this particular time point. And after 4 weeks, another 3 logs increased. And at that time, the ALT was already 475. And then we start the patient with entecavir, and luckily, these patients actually had a control rapidly of the DNA, and with the peak of ALT 1,300. And for that particular patient, we successfully, or luckily, I would say, contain the flares. However, this, I think Professor Lampertico will also talk about in much more detail. But in brief, even in a very well-defined, controlled clinical trials, we sometimes encounter very bad flares, very rapid flares, resulting in liver decompensation with a poor result requiring liver transplantation. So, ladies and gentlemen, I would like to conclude by saying that ALT flares are common in patients receiving surface antigen-lowering agents, including siRNA, ASO, NAP, and anti-PD-L1. The chance of ALT flare seems to be correlated with the magnitude of surface antigen reduction, the rapidity of the surface antigen reduction. Preliminary studies showed positive T-cell activation in close relationship with the surface antigen reduction and ALT flares. ALT flares is comparatively less severe in NUC-treated patients compared with treatment-naive patients. ALT flares, because of the surface antigen reduction by novel agents plus or minus activated interferon, can result in loss of surface antigen. And ALT flares can be very severe in patients who stop NUCs, and we really need, a very cautious approach for monitoring for these patients. With that, I would like to thank for your attention.
Thank you very much, MF. Please sit on the podium here. So the next speaker is also quite well known. It is Pietro Lampertico, University of Milan, long-standing interest in hepatitis B and trying to treat and cure it over the decades. And the title of his talk is Why Should We Be Careful Using Nucleoside Analog Withdrawal as a Therapeutic Option? Pietro.
Well, thank you very much, Harry, and thank you very much to all the organizing committee for this invitation. I like the title, Why We Should Be Careful Using Nuke Discontinuation as a Therapeutic Option. So very challenging title. These are my disclosures. I will try to cover the issue of nuke discontinuation in clinical practice, as well as nuke discontinuation very briefly in clinical trials. I will not cover the issue of nuke discontinuation when you achieve S antigen loss, because this is standard of care. I will only cover the issue of nuke discontinuation before S antigen loss, and only in the setting of patients without any evidence of cirrhosis, as is currently recommended by guidelines. So why do we want to stop nuke before achieving S antigen loss? On the left side, you see all the reasons why you should not stop. Excellent therapy, easy therapy, improved survival, overall very cheap and very easy to be managed, long-term suppressive therapy. On the right-hand side, some possible reasons why you would like to stop before S antigen loss. I will basically cover the last issue, which is, can we stop before S antigen loss to achieve S antigen loss? That would be a strategy which has been suggested. And this is really the summary of the sort of strategy that we highlighted a few years ago together with Thomas Berg in this editorial. So overall, here we are including several studies and many years of activities. Basically, you have three different phases. You start from the left side, a stable situation on therapy. Everything is easy to be managed on therapy, PCR negativity, normal T. Then you stop oral therapy. You enter the second phase, where basically characterized by instability. You start to increase DNA, ALT, potentially go high, and this phase will continue with different really clinical situations for 1 year, maybe 2 years. And then the last part on the right side, you have, again, a sort of stable condition, which corresponds to the long-term outcome with different rates, with different results, according to the population, to the clinical setting, to the studies, and so and so. So why do I think this is a challenging situation? First of all, because of the endpoints. So the question is, what is the endpoint of this nuke stopping therapy? For you as a doctor, for you as a patient potentially. So this is something that we have to define before stopping therapy. It's not easy. Which is the endpoint? S antigen loss, inactive carrier state, normal health therapy, or no treatment, or no retreatment? This is something that is very difficult to be defined before you stop. You have to talk with your patients. And timing, of course, is also relevant. For example, look at these two studies. On the right-hand side, the Toronto STOP study. On the left side, the FINAT study from Germany. And you look at the S antigen levels, S antigen loss. On the right-hand side, Toronto, I think there was one single patient who achieved S antigen loss over 45 patients. On the left side, you see the German study, for 10% of the patients achieve S antigen loss. So even if you achieve S antigen loss, it will be a very rare event. And according to whether you live in Toronto or in Germany, they would probably be very different, and probably because of different genotype, the antigen status, Asian ethnicity, and so and so. Well, if you change the endpoint and you go for, HBV DNA, well, which is the best strategy? Continue therapy or stop therapy? Well, if you continue therapy, there will be very super good results, 99.9% suppression. If you stop therapy, everybody will relapse. Again, probably with different kinetics, comparing Toronto study and the FINAT study. And what's about ALT again? We all agree ALT normalization is important. The only way to achieve full suppression of normal ALT is to continue oral therapy. If you stop significant flares in both studies, again, probably even more relevant in the Toronto study compared to the German study. Well, your endpoint could be retreatment. So no retreatment could be potentially a good endpoint, not from my point of view. But what is the probability that you have to restart therapy? 40% in Greece, 40% in Germany, 38% in Canada, 41% in Taiwan. So very similar across the studies. 40% will restart therapy, so 60% will probably remain without therapy. That does not mean PCR negative or with normal LT, for sure. But there is another issue which makes this strategy very complicated. It's timing of retreatment. On the left side, you see a study from Taiwan, a large study looking at the probability of S antigen loss over time after nuke discontinuation. And please look at the group A and group B. What is the difference? Group A, they had a clinical relapse and they received early rescue, no S antigen loss. Group B, clinical relapse without early rescue, yes, 18% of S antigen loss of therapy, statistically significant. So the message from the study is that, yes, you are not too early retreatment, but at the same time, not too late to avoid severe flares. Again, this is very complicated in clinical practice, super complicated. What about predictors of response? And that's another issue which is relevant. We don't have strong predictor of response. This is a very nice study from UK, Kosh Agarwal group. They look on the right-hand side, trying to predict not S antigen loss, not PCR negativity, but just flares. On the right-hand side, 4 patients had a severe flare of therapy, more than 10 times upper limit to normal. The only two predictors were high HBV RNA levels and high correlated antigen levels. No difference in terms of S antigen levels. But this is a super small study, never been prospectively validated to my knowledge. What's about S antigen levels? Again, this has been already mentioned, a very nice study, 13% S antigen loss of therapy over 48 weeks. But that's the probability of achieving S antigen loss is only confined to specific patients. White patients with S antigen levels below 1,000, Asian patients with S antigen levels below 100. But not all these patients will achieve S antigen loss. And please remember, the Caucasian patients were very, very few in this study, and this is retrospective study. I don't think has been prospectively validated. If you change study, the number will change again. In this very large study, retrospective, mainly Asian study, well, the best predictor is antigen below 10, 5% of the population only. If you go for highest antigen levels, you need correlated antigen. And then even in these 10% of the overall population, retrospective study, not all these patients will achieve S antigen loss. So this is very difficult to use strategies over time. What about flares? Again, we already covered this issue in parts. Significant flares following DNA rebound, potentially different in the Toronto study compared to EU studies. What about the good flares? What about the bad flares? Right-hand side, well, technically speaking, you should make a differential diagnosis by looking at the S antigen kinetics at the peak of ALT. Beneficial means S antigen goes down at the peak. Bad flare means S antigen goes up at the peak. Well, but that's very complicated in clinical practice. This is very nice, a nice study retrospectively. I will challenge you to make this definition on a real live clinical practice. And sometimes things can go wrong. I know MF already alluded to this case. This is a nice case from, well, it's not a nice case. That's an interesting case from the RIF2 study. 54 years old male from Hong Kong, probably genotype B or genotype C, has been on therapy for 10 years on TDF, very good fibroscan, very low DNA, very low S antigen levels, randomized RIF2 to no therapy, which is good probably. And he was on TDF for 1 year, he very low S antigen levels, normal T, negative DNA, and then he stopped TDF, the first kind of green arrow. And then he had initially almost nothing, but already a significant DNA increase. And then the situation got wrong very, very, very rapidly. He was lucky. He was in London. He got a liver transplant. Rescue therapy was not successful. So be careful. This was a case enrolled in a randomized controlled trial. And I got this information a couple of days ago from J&J. It was HBV RNA negative at the end of therapy, but 4 logs of core. You cannot stop in NUC in these patients, which is not typical for e-antigen negative. This is typical for actually e-antigen positive patients. What's about the management of these two strategies? This is a sort of personal simulation. If you randomize someone to continue oral therapy on the left side or to stop oral therapy, well, that's a lot of work. That's a lot of monitoring. That's a lot of tests you have to ask, check, and make a decision on. Very complicated. And look at the lower part. You need a super good doctor, a super good expert center, a very good compliant patients. So this strategy cannot be used to improve hepatitis B functional cure in Asia, in Africa, in South America, where you cannot even use long-term oral therapy. So in my view, there are two strategies. Strategy number 1, let's go for S antigen loss on therapy, during whatever is the drug you want to use, NUC or new therapies, and confirm S antigen loss of therapy. Strategy number 2 is much more complicated. I would not go for a strategy which requires NUC discontinuation or drug discontinuation, new drug, to achieve S antigen loss of therapy, specifically if this requires significant ALT flares. But there are some special situations, new situation. Again, I'd like to mention again this study from the RIF2 study. On the right-hand side, you see the ALT profile of patients who stop NUC without anything else versus those patients who stop NUC after 1 year of siRNA and CAM. And actually, the ALT profile is completely different, even though the DNA profile is different, but not completely different. And if you look at the lower part of the slide, right-hand side, 35% of the patients who stopped NUC before S antigen loss had a significant ALT flare, compared to only 3% of those who were, let's say, pre-treated somehow with siRNA and CAM. I don't know the mechanism. Maybe CAM is not relevant. Maybe siRNA is relevant. The difference is also S antigen levels were lower in the second group compared to the lower one. Therefore, but this is potentially opening a new avenue, a new strategy. One issue is the long-term outcome. Let's do everything we can to improve the long-term outcome. But another possibility, which is new, is also try to improve how we get to the final outcome. So basically new strategies to improve, optimize how to reach the favorable outcome. For example, making the off-treatment management much easier, much safer. So in conclusion, ladies and gentlemen, dear moderators, I think in selected non-cirrhotic antigen-negative patients, discontinuation of nuke before antigen loss is possible. But this strategy, is very complicated. It's very complicated. It's not applicable in most of the centers. You see all the reasons that we already mentioned. So in general, in my view, new antiviral therapy should aim to achieve antigen loss during therapy and use the off therapy only to consolidate. And however, new treatment strategies may eventually suggest new possibilities to simplify nuke discontinuation. And if you really need an LT flare, because your drug will require LT flare, make sure these flares are mild, short-lasting, predictable, and associated with high rates of functional cure. Thank you very much.
Well, thank you for that excellent presentation to all our speakers. And I'd like to remind folks that are watching online to use the question function, and we've got an iPad right here at the stage where we'll field those questions over the next 50 minutes. But we'd like to open this session up for questions.
So I'll start. I kind of want to ask MF and Pietro. I mean, seeing all that data together, MF, and the same one from the different treatments, and seeing the S antigen decline, the LT go up, it's fantastic to see that all put together. One of the things that I've never really understood is why does ALT take so long to come up? If we're thinking these S antigens going down, maybe the hepatocytes are getting killed or something, and it's released from dead hepatocytes. When you use the TLR agonist, for instance, you see the cytokines in the blood in 4 hours, but ALT can be 1 or 2 weeks after we start to see these antiviral events. Do we know any reason? Is this a sensitivity of the clinical assay? I mean, why is ALT so delayed?
I thank you, Adam. In fact, I don't have a very good. I don't have a very good answer. But my postulation is, when you have the drop in the surface antigen, you should have a drop of surface antigen that induces immune attack, right? So when you have the drop of surface antigen, will the immune attack be immediate? I don't know. So what we saw in the graphs or the profile, we see the decline of surface antigen, but we don't know when the immune actually, start working on the infected hepatocytes, and that will have ALT flares. So we have a window where we don't know the drop of surface antigen and the time of action from the immune system. So that may account for why we see a sort of, not immediate increase in the ALT flares.
For the nuke discontinuation clinical setting, I think is probably easier. Is related to the DNA replication. You need for probably reinfection of many cells, widespread diffusion of cells with high level replicating DNA, and then when the DNA will reach a specific set or level, which is probably individually driven, is not absolute, then you will get an ALT flare that, by the way, will be also variable in different patients. So in the nuke model, I think is really strictly related to DNA rebound, no DNA rebound, no LT flare.
Go to microphone 1.
Can I ask a question in this, what we just discussed, particularly to Pietro? There's a lot of people from industrial partners, from pharma in the room, right? And they're struggling with the flares and how to deal with them. And and I agree with you that we should aim for S antigen loss during treatment and not off treatment. But then what would be your time point of stopping nucleoside analog? Is it half a year afterwards? Is it a year after the patient has become HBs antigen negative? And basically, we typically stop the experimental medication and then we move on with consolidation. For how long?
Well, hi there. Harry, I don't think we have the answer. I think it's probably, I don't know, 24 weeks. But this is really generic. Why 24 weeks and not more? In real life, we tend to wait for the anti-S production. That's a very good marker. But this, again, with interferon and with nukes. With new drugs could be a little bit different. I would say, in general, 24 weeks would be probably safe enough.
Would it depend on the target engagement, the mechanism of action at all, or not really? Which would make it very complex, actually.
Potentially, yes, but then it would become very complex.
I think theoretically is yes. I mean, you were talking about siRNA, I don't know, ASO, you see a sustained effect. So if you have a patient who lost surface antigen today, so the effect is still there, you will stop all, right? So then they may still have a high chance of getting maintained, sustained surface antigen loss. And back to the question of 24 weeks, in fact, I would say this is more, individual, a decision, all right? But my practice is usually take, 24 weeks to observe. The surface antigen is actually stably, negative. Then I stop.
We've got a question up. Oh, sorry, microphone one.
Pietro, I enjoyed your talk. I agree with you. I tend to treat until patients are surface antigen negative, but in the real world, when you can't measure DNA that frequently, and you're relying on surface antigen and ALT, really, I guess my question is, what's the lag time between a surface antigen flare or a DNA flare when you can't get to DNA? Hopefully you're not relying just on ALT alone, which is, we all know, a later marker.
Yeah. Sorry, are you questioning the timing of the monitoring or what? Sorry.
Yeah, what's the difference between the DNA flare, the peak, and say the surface antigen rise? Is that 4 weeks or 6 weeks, or how often do you measure that?
Well, if you look at the REEF2 case, that's very clear that the kinetic is very clear, as we would expect it. So you have the DNA increase first, and then you have the S antigen increase together with the ALT elevation. So S antigen in the nukes discontinuation model, S antigen levels are increased after everything. It's a sort of late event. I'm not sure it's reasonable or is expected, but that's the situation. So you do not have to look at the antigen levels to make a decision, let's say. It's too late.
I think, if you're talking about stopping nukes, there's no way to replace the measurement of, the DNA. I show you the example. The DNA actually increases, very rapidly over 1 or 2 weeks. And then you really need to catch the time where the patient is really having a very rapid viral replication. So, if you're relying on surface antigen, then that will bound to have delay in consideration of retreating the patient.
Sometimes you can't get DNA every 4 weeks.
Right.
That's why I agree, completely with Pietro. If you consider to stop therapy, that can only be done in a very highly selective centers where you have, monitoring. In fact, my experience of all these patients is really, really scary. When you receive a call from your colleagues, the ALT was 2,000. Then you ask the colleagues, so every two days you check the blood, etc. But except for just adding back the nucleosides, you have nothing to treat the patients, and you are in the face of, say, a scary time over weeks or so, in order to have, say, save patients back from treatment. So, again, as I said, very cautiously or in a very highly selected center.
You know, I think in listening to this, it's something that I have not in my clinical practice stopped nukes for all the reasons that were discussed. Yet in my clinical trials role as principal investigator, we're doing that inherently to prove that we've achieved functional cure. It is a built-in risk to finding finite therapies that lead to increase in functional cure. I'm wondering how we manage that and get that kind of sweet spot of restarting a nuke before, as we've discussed. But then when thinking about rolling out these out to clinical practice, we're going to need to have very good predictors of who's successful and who's not. It's a really important topic, both for clinical trials, but also for the implementation of successful therapies from clinical trials.
Yeah.
Adam, go ahead.
Yeah, I mean, I want to make a quick comment on this topic, then also ask Morven a question. So I think, Pietro, you kind of hit on this idea of the kinetics, and this is kind of my feeling too. If it's going up very fast, if it's going down very fast, you get this almost perturbation or disruption of the equilibrium that induces, in my feeling, probably an innate response that starts inflammation. Then you might get some antiviral effects of the T cells coming after that. And I think that the siRNA data and these studies where they're stopping after treating with siRNA and you get this slow rebound, you don't see it, right? I mean, it's all about this kinetics, it really seems. So thinking about the mechanism of action of drug, how to stop them, and the safety of stopping them is probably going to be key to that aspect in understanding finite therapy or keeping them on nukes. I don't know if you wanted to comment, but if not, I have a question for Morven. Because Morven, in the checkpoint inhibitor treated patients, you know, you gave this sort of predicted window of hepatitis, you know, and it seems to happen sort of the same window as patients that stop nuke, right? This sort of 8 to 24 weeks after starting the dosing. I mean, I know these are the general feelings, but I mean, how many doses of checkpoint inhibitors are given? Have there at this point? Is it 1? Is it 2? Do they know sort of these early inflammatory profiles in the plasma? Is there any data on this?
Thanks. No, it's a good question. It depends a little bit on the regimen, the treatment regimen, and the timing can be earlier with dual therapy. Normally the dosing is every few weeks, every kind of 3 weeks, so they can be several cycles in by the time they develop toxicity, but the latency is very variable. There's been a lot of work done in various immune-related adverse events, including hepatotoxicity, looking at lymphocyte to platelet ratios, changes in baseline, generally white blood cell markers, and trying to predict the toxicities. Maybe, but the data is quite conflicting. There hasn't been a clear signal to indicate when patients are at risk of developing, if there were baseline predictors, or when patients are starting to develop that inflammatory process. Interestingly, we haven't studied it and haven't seen clear literature on it, but my oncology colleagues in melanoma tell me that they do seem to see a kind of an early syndrome where the liver enzymes just start to tick up and the patients develop a kind of a grade 1 hepatitis, and that seems to herald a more severe grade 3 hepatitis a couple of weeks later, and sometimes with some pyrexia. And they're starting to take that, very anecdotally, but they're starting to take that syndrome a little bit more seriously and monitor those patients a bit more closely. But that's not published. That's very anecdotal experience.
Is there a sex difference in hepatitis, ICI hepatitis?
No.
So we're going to go to microphone 1, and then we're going to take some of the online questions. So,
continuing the questions to Morven, in oncology, is there evidence that the safety or this immune-related adverse event titrates as function of concentration of the checkpoint inhibitor that is being used? That's one of the questions. So, for example, using a lower doses, would you expect, or is there evidence that you will see less EARs? And that's one of the questions. The second question is, can you maybe hypothesize or speculate what is the reasons for developing anti-PD-L1 targeting of the pathway, assuming, keeping in mind that there is another ligand, PD-L2? I mean, what is the rationale?
Okay. Okay, the first question's much easier to answer. There is data for CTLA4 inhibiting therapies, specifically ipilimumab. There is a very clear dose response in terms of toxicities. That hasn't been demonstrated for the PD-1 or the PD-L1 targeting therapies, and it seems a kind of on-off toxicity, no toxicity. From the doses that have been tested on the oncology literature, I will say, which I think are a little bit different to doses that have been used thus far in viral hepatitis. I'm not sure I have a great answer to your second question. I think it was around the use of PD-L1, given that there is also the PD-L2 receptor, is that right? I honestly don't think I have a good enough knowledge of the drug development in this realm to be able to answer that question, I'm sorry to say. I'd be happy to hear if anyone else does, though. It'd be interesting.
Well, maybe we'll continue with one of our online questions that's on the checkpoint inhibitor theme, which is talking about specifically patients with hepatitis B, whether it be inactive or active, who receive checkpoint inhibition as part of chemotherapy, talking a little bit about the outcomes for the hepatitis B, whether it flares or what we've seen.
So again, specifically, I didn't include this in the talk in the interest of time, but it's obviously a very relevant area. So clearly the patients with viral hepatitis and other cancers were excluded from a lot of these clinical trials, except in the case of hepatocellular carcinoma, where clearly pre-existing liver disease and viral hepatitis was relevant. Certainly in these settings, all patients had to be on a nuke or an antiviral agent and have well-suppressed viral DNA, virtually undetectable, or certainly less than 500 international units, depending on the study. In those studies, there have not been hepatitis B flares. There have been some earlier studies looking at patients with HCC treated with anti-CTLA4 tremelimumab. There was an association with some ALT flare and actually a reduction in the hepatitis C viral load in those studies, but not to a kind of a treatment-limiting or clinically significant degree, if that answers the question.
Bob Gish?
Thanks. I want to highlight what we've learned from the Hepatitis B Foundation about stopping drugs, stopping medications, and we have calculated about 40% of patients self-discontinue their nukes somewhere between 3 and 5 years of treatment. So I think the concern about flare and death has been exaggerated because of our clinical practice, our patients that we see in clinical trials, or situations like in Taiwan. If there's that many people stopping on their own, not being monitored, we would have a lot higher death rate or transplant rate we would be seeing, I think. But ultimately, this would require some type of survey to find out what the self-discontinuation rate is and what the consequences are. Is it over-exaggerated, or are we going to be safe doing this? The patients want to stop, so that is the ultimate goal. The patients, to get people on therapy, we need to have finite treatment.
Can I just make a comment, an answer? We had one case in our unit. He discontinued despite our indication to continue. He had a severe flare and he was transplanted. So this is something that we see outside clinical trials, outside predefined strategies to stop therapy. So not all the flares, of course, can lead to severe dysfunction of the liver, but I think that's a real risk.
We have a similar experience in Grishma. I think you looked at it. We do 200 transplants a year in Toronto. We looked at the patients who were referred for hepatitis B transplant without a setting of HCC. I think we had I don't know, Grishma, was it 8 patients that self-stopped nucleoside analog and had to be transplanted for that. So it is definitely not without risk. And it happens a lot. It happens a lot in China where it's not well reported, obviously. So I think we have to be very careful. Marion?
Yeah, Marion Peters. I have a question about clinical trials. If you're stopping all finite therapy, should stopping nukes depend on the level of surface antigen at end of treatment? And if so, should it be different for different ethnicity genotype?
This is the question of partial cure, basically.
I think, we consider to stop nukes in the clinical trial. So I think, obviously, people want to have surface antigen loss before you consider the stop, but the chance is low. So people then say, okay, why don't we stop at the level of less than 10? And pretty much safer in terms of the rebound. And I think, this can be the goal of stopping if the patients have end of treatment surface antigen less than 10. But I still have some, reservation of stopping at 100 when you consider, stopping, nukes in clinical trials.
Well, we can go to another online question, which let me go back. This is from Ashwin, talking about getting back to, this question of ALT flares and predicting that. And he was asking the question, is it related to the number of infected hepatocytes? That, some people, when you stop, they'll probably have less and other people have more. And can we predict that, I guess is the question.
I think this question cannot be answered. Unless we really do a very delicate study on looking at the load of the infected hepatocyte in the liver. So what we see, we don't have the predictions. Some patients, they have very bad flares and they are young. The baseline, when they start therapy, the baseline, DNA may not be sky high. So that indicates that the load may not be too high, but we still see, very bad flares. So I would say, we can't, at this stage, be sure whether these patients have less infected hepatocyte, in theory, should have a lower chance of flares.
And in the meantime, well, I have a question for you, Morven. So there is new, very nice biology to give oral compounds as checkpoint inhibition, and also compounds that claim to be more targeted to the liver, so that you would have less autoimmunity elsewhere in the body, right? What is it? How is that going to affect our future development of hepatitis B treatment, if you would know at all? Is it true that you could target that and then, well, exclude immune thyroiditis, colitis, pneumonitis, whatever, and target these drugs to the liver?
Great question. I think it's a tough one to answer. I think because I think we don't know enough really about what drives the checkpoint inhibitor toxicities in the setting of cancer. How much of this is driven by the primary tumor, crossover of cross-reactive T cells, immune and other immune effects. It's deliberately slightly hand-wavy because the literature on this is still quite hand-wavy. And how much of this could relate to, other release from inhibition of other prime T cells that's actually not so much related to the tumor. So I think until you answer that question, it's then quite difficult with any immune-related adverse event. And then specifically taking that to hepatotoxicity, it's difficult to know how much, general versus targeted therapies are going to make much difference. The patients, it's slightly analogous to what you're saying. The patients that I personally come to me in the clinic that I find the hardest to treat, and again, when I'm in a forum like this, I always ask if anyone has better strategies than I do, if they can give me some help, is the patients with HCC who are being treated with checkpoint inhibitors, because they're noted in the literature to develop a higher risk for hepatitis, but the rate of immune toxicity seems the same as other solid organ tumors. So there are all of these other, presumably either tumor effects or immune-mediated effects going on in the liver. And is that checkpoint inhibitor hepatitis? Is it a ALT response related to tumor killing? Is it bystander effects that isn't strictly immune-related hepatitis? What do you treat? What do you not treat? Those are very, very difficult questions to answer in HCC management. And I think they have the potential to be difficult questions to answer in other liver diseases where you're using checkpoint inhibitors. It's not quite your question, but it's a tangential answer.
I wonder if I could just push a little bit on oral therapies, the idea of a shorter receptor engagement, an on-off switch. So you dose it, something bad happens, you stop, versus the monoclonal antibody approach with longer receptor engagement. Do you think that will change the AE profile? In other words, can we stop ALT hepatitis by just stopping dosing? And you talked about some of the timing.
Yeah, absolutely. And I think that's, for want of any better explanation, that seems to be the best explanation for why the toxicities kind of last for that long and then seem to kind of just switch off, and you don't need, different to other types of autoimmune hepatitis, for example, you don't need longer courses of immune suppression. So yeah, I guess in theory, yeah, if you have less receptor engagement, you're not going to drive that continued effects on the immune cells. But I guess the proof will be in the pudding, and we'll have to see when we start using some of these therapies.
Okay, maybe Jordan first and then Adam afterwards.
Just following up, Morven, we're putting you in the hot seat here, but it's an important point for discussion. So it's a little surprising that there isn't a difference in sex and the risk of these immune-related adverse events. What about age? Because cancer patients tend to be a lot older than, we could think about in the hepatitis B spectrum using this early in disease or potentially late in disease. And I guess, so that, and my next question is going to be, is part of the problem that we're not defining this well enough? So much of in the cancer literature is kind of empiric treatment without really, like, if it looks like a duck, treat it like a duck. They don't really investigate it very carefully. Do you think we could define the risk profile better if we better defined the disease?
So the first
question was age.
Age, yeah. So there's no clear signal towards differences in age and risk of immune toxicities. It gets messy because there's a lot of different primary cancers. There's different treatment regimens, trials versus non-trials, previous lines of therapy versus not. A lot of the literature comes from melanoma, where there's actually a very diverse age range, although generally, as you say, malignancy tends to cluster in the older groups. There hasn't been a clear signal to an influence of either sex or age on the risk for toxicity.
Even though the pre-existing autoimmunity, which is so much more common in women and tends to increase with age, it's surprising that is not it's just shocking in a way that that's not a driver.
And there's no clear signal to pre-existing autoantibodies with the risk of development of toxicities. That was postulated as one reason for predicting who might be at higher risk. Is there pre-existing autoimmunity, particularly humoral autoimmunity, that you'll unmask? But even if you detect, thyroid antibodies, there's no clear association with patients then going on to develop autoimmune thyroiditis. So whether, yes, you have this tendency to autoimmunity in younger women, which is not reflected in the immune check. I think, to me, it just reflects a different mechanism of action with the two processes, and this is not the same as autoimmunity. It's a bit different and a bit more complicated. I've forgotten your second question. I'm sorry.
It was just about whether we need to, biopsy these patients or really to understand the disease better, a bit better, to understand the risk profile.
Absolutely, yeah. There's a move away. The oncologists hate biopsying the patients because their main argument is potentially delaying treatment. But I think the only way we can start to tease this apart is with more tissue and more histological understanding.
Okay. Go ahead, Massimo.
The real point is that in real life, oncologists check liver profile enzymes just when the patient is coming back for the next injection. So we have very limited appraisal of all this. It happens that I am in a tumor board for immunotoxicity. We discuss something like 50 immunotoxicity every 3 weeks, and no sex, no age, autoantibodies, no way. The only real things are ipilimumab, CTLA-4, double therapy that is really marking the things. Even histology is different. And the other point is that oncologists tend to give steroids very fast. So I think it will be really difficult to go much. There are some good studies, but in real life it will be very, very complicated. And a lot of times you have small elevation of transaminases, and you have confounding factors, axitinib together, even augmentin. Is antibiotics. So is a mess, complete mess to really have this kind of early signals to conduct. It's much easier to discuss afterwards. And in oncology, obviously, they want to continue. until the patient is like that, and they want to start again. So we are re-challenging a lot now, a lot, even for grade 3 toxicity.
Okay, Adam?
Yeah, I wanted to come back to MF and change the topic again, because still thinking about these differences in flares between the siRNA and the antisense oligo. I mean, the GSK has shown some inflammatory cytokines in the plasma and sort of gives you an explanation as to why those patients would develop an ALT elevation. I don't know of any of this data in the siRNA drugs. Have you, I mean, I'm just asking if you know of any data basically to show that there's at least an innate immune activation.
I think, I mean, Airbutis actually have done some data on the cytokines during the therapy. So they also show that, I mean, there's an immune reactivation that are associated with the surface antigen decline. So these are the two, I mean, main, studies I know. They actually at least demonstrate to a certain extent the action of these drugs.
All right, I'll have to look for that then. And I guess the second question I had is around your data when you presented the BEPI, and you were showing it's only a handful of patients here, but the untreated patients seem to have much higher ALT elevation. We know the nukes reduce inflammation, right? Because they sort of prevent the reverse transcription of the pgRNA. Our data suggests that the nukes actually remove the pgRNA when we look at our single-cell RNA sequencing data. So, in this context, is there something, I mean, it's more of a hypothesis, I'm not really looking at an answer, but, the idea of just maybe the particular transcripts that are available for engagement of these drugs might actually be impacting their inflammatory responses. Yeah, that was thinking out loud, sorry.
Can I ask one question before we go to the next question in the floor to MF and Pietro in particular? Should we put all patients on nukes? Because flares, we can call a flare a good flare, but a flare is good until the patient dies, basically, right? Or until the patient develops liver failure. I've seen patients where the viral load, the S antigen went down, but then got in big trouble. So from now on, should we always use nukes to dampen that effect, or or would that be detrimental to the chances of response? What is your thought?
Well, my idea is that you should go with nuke in all the cases and eventually try to go backward and eventually later on try to show that it's not relevant. But I would protect patients with nuke.
MF, what is your thought?
I think when you look at the GSK data, they have full populations of patients on nukes and patients not on nukes, and then the response is actually the same in terms of the end of therapy. So I mean, to answer your question, I think putting patients on nukes probably won't affect the efficacy of all the novel treatment, but it will be safer, obviously. I mean, when the patients develop flares. But I mean, unlike the patients who stop nukes, I think, patients on therapy during flares, I tend to be more comfortable. I would say, okay, every 4 weeks come back, rather than every 2 days. I mean, in these two different groups of patients.
Yeah, I think it was a similar comment and question to Bob Gish's question. It's just, what is overestimation? I mean, say 10 patients stop on their own, even one, say 9 of them have good flares or whatever, even that one bad flare, is it worth, because the alternative is continuing treatment. So is it worth stopping patients? And especially if they're stopping on their own, we're not monitoring them. I know Scott, Harry, all of them have had patients who've just presented with liver failure because they stopped on their own. So it was more just what are we willing to accept, or in terms of like how many bad flares can we accept?
Well, if I can make a comment, well, one issue is that we have a problem every day because some of the patients will stop nuke independently of our indication. That's one issue. The other issue is that we stop nuke proactively. And I don't think this is overall a very good strategy unless this is a strategy which is performed in very selected centers. So I would not combine the two situations because of course, some of the patients would stop because of any possible reason, but that's not a good reason for us to stop therapy in all the patients or in most of the patients.
Yeah, maybe I'll comment on this. The other issue when people stop spontaneously, they are often lost to follow-up. The assumption is they'll come back to my center and either be well or transplanted, something will happen. But the reality of it is they may not come back to my center. They may have a serious outcome, far away from where I was treating them. I don't know, and that's the problem. If we're not measuring outcomes in these spontaneous patients who stop, then I think we don't really know what the outcomes are. And I think we can't necessarily assume they're benign. And then the second question, just the way, what risk is acceptable, I think that's one of these situations where we have to ask the question, to whom? And really, I think that's where people with hepatitis B who are going to accept a risk of stopping therapy, if that's the paradigm we propose, really need to be involved in answering that question, what risk is acceptable?
Maybe to move on that topic and be the devil's advocate. We posted in the guidelines that it could be considered to stop treatment. Should we even go back to the drawing board, say, well, we don't like to do that, and it first has to be done in randomized controlled trials, or what is your view, Pietro? This is a difficult topic, I presume, and yeah, I was also part of making the guidelines. So it is. What should we do with these new data?
Well, I think in that guidelines 2017, I think we were very conservative at the end, because if you look at the wording at the text, we're in selected non-cirrhotic who we could consider potentially stopping therapy if, and if. So I think those guidelines, I think overall are still kind of good today. I would not change.
Right? So people, don't read guidelines very carefully.
Well, but that's another topic. Okay, but I think the message was very selected patient, and today all the data I showed to you and also MF are suggested that is possible in very selected patients, provided that you are expert and so and so and so. So I would not change really dramatically the recommendation today, 5 years after.
This is Michael Birmer from Janssen. Pietro, thanks for reminding us why we were so concerned to retreat too early. I think the data on your slide is clear, but I don't think this is enough of evidence. And I don't think that we really kill the patient's chance to get to functional cure with retreating early. We have patients where the starting of NUC did not negatively influence the reduction of S. So I think that has to be challenged. And then to your comment on the correlated, I think in retrospect, I would agree, maybe correlated also with what we know from the Asia-Pacific region, should maybe be a parameter that is taken into account for stopping or not. In time of design of the study, that was not in any recommendation, and it was also not in our thinking. So I would like to say maybe less that something was done wrong in this case. Not that you said that, but we learn along the path.
So to the first issue, I wanted to be a little bit provocative. That study is a large study from Taiwan, well published. I agree with you. I'm not completely convinced that timing of rescue is so relevant in the way that too early is bad. I'm not convinced. Other studies do not go in the same direction. In terms of additional markers to stop therapy, of course, these are new data, brand new data, and there are some studies around suggesting that, again, S antigen levels with or without core, or even core antigen before stopping NUC could be relevant. In the near future, I foresee a change probably in this indication, suggesting companies to do more biomarkers before you stop therapy. That's, I think, is reasonable.
Go ahead, George. Yeah.
Well, just a comment to follow Michael's point. The Hepatitis B Research Network did a sort of planned withdrawal after long-term nuke, after 4 years of nuke therapy, and we really saw no benefit to, and we had very sort of, I guess, I don't know whether you could say conservative or not conservative, but we allowed people to really flare. Restarting treatment, they had to have a severe hepatitis or evidence of liver failure, and we saw no benefit of having big flares compared to little or no flares. So I think the argument, I take the Taiwanese data, I know they're published, but I think we should be a bit cautious about saying you've got to let people flare to see a benefit. I think for the most part in the nuke withdrawal setting, flares are not beneficial, and most people that clear S, it's more of that petering out, where they may have a little tiny bump, but it's mostly just loss. Now that might be different with the new therapies, but with just nuke withdrawal, if there's going to be any change to the guidelines, my push would be to say have an earlier trigger to restart therapy, and whether that's a DNA threshold or, but I wouldn't let people flare just to hope that there's a benefit.
Yeah, if I can make a comment, I think that indeed there are some major differences. If you compare the Toronto study, for example, with the Greek studies performed in Greece, studies performed in Germany, they are very different in terms of many issues, included the ALT flares. Probably, E antigen negative genotype D patients probably have a different profile compared to the Asian, now E antigen negative, but with a long history of antigen positive genotype CAB. So there are, I think, major differences. I'm not a good virologist or to understand why, but from the clinical point of view, they are very different, although they look similar, let's say.
Well, great. Well, we have no more questions online, and I think what we'll do is call the session to a close. It's been a really fantastic morning with great discussion in both sessions. I'd like to remind everyone in the room as well as online to complete the online survey, which we sent at the end of the day. And then for those of you who are here with us in the room in Toronto, there is a group photo that you have to complete before lunch, and that will be outside the meeting room in the Ottawa room. And then we'll break for lunch and come back here for session 3, which will begin promptly at 1:05 p.m. So next step is the group photo. Thank you.
Thank you.